So I'm Przemyslaw Twardowski, and I'm a medical oncologist specializing in urinary tract malignancies, including prostate, bladder, kidney cancer, and testis cancer. And I work at John Wayne Cancer Institute, which is part of St. John's Providence system in Santa Monica, California. So that's where I practice. So I was talking about a specific subset of patients with prostate cancer who have evidence of early relapsing disease after surgery or radiation therapy based on just a blood test elevation. So the subject was how to identify, stratify these patients into various risk groups and how to manage them. What's the therapy? What are the therapy options? They are definitely transforming the field. It seems like the data suggests that the earlier in the setting of the disease you use them, the more benefit you get. The question is how early you're going to see it. It started initially in very advanced disease after chemotherapy, failure of hormone therapy. Now we're moving it into pre-chemotherapy and in combination with early hormone therapy treatments. So, and there's actually several agents now. That's one of the hot areas in prostate cancer. It's very intriguing how, even though the whole concept of hormone therapy is so old, it actually goes back to 30s and 40s of 20th century, we're still finding a way to refine it with these better drugs that still address the same pathway of growth of this disease. It's quite variable. Where I practice, patients tend to be very well educated, but not always. There are some patients that don't know about these new drugs. So it really, you have to kind of gauge it initially when you meet the patient. And sometimes it's the patients know the literature so well and quote me the articles that I barely know about. And then on the other side of the spectrum, patients are just kind of more relying on physicians' recommendations. But I would say that in majority of cases they do know. Well, I think I did mention that. First of all, maybe it's as easy as it is for me to say, don't panic. I mean, I quoted some numbers indicating that it's not any imminently life-threatening circumstance, and usually you have a lot of time to think about it. So that's, I think, one of the important points. Don't rush to any decisions. That situation typically is not associated with any threat for years to come. So you certainly don't have to make any decision in a month or two. You can take your time, gather an opinion from various subspecialties. Pick a doctor that you trust. Get the second, maybe even third opinion. I think that's probably, honestly, the point that I wanted to get across, because obviously it creates a lot of anxiety. It may indicate that the disease hasn't been cured, but it's a relatively unique subset that is definitely well managed, but some what I call tincture of time sometimes is good. Just watch it for a while and see what's the pattern of PSA, how quickly it's going up, and make a decision after at least a few months of follow-up.